So why not top up his testosterone level? While we need intratesticular testosterone for spermatogenesis, the administration of exogenous testosterone suppresses spermatogenesis, which the WHO contraception studies showing that 96% of men administered testosterone on a monthly basis are azoospermic by 12 months. When I chaired the testosterone guidelines panel for the AUA, we came up with a statement that T therapy is indicated for men with low T plus signs or symptoms, and that includes infertility. However, the symptomatology is nonspecific. There are men who have low T who have infertility whose infertility may not, in fact, be due to the low testosterone. Men with low testosterone and symptoms, but those symptoms may not be due to the low T. In fact, we know that outside of the validation studies, that men who have high symptomatology consistent with low T are only 25% of them have low testosterone levels. What about the men who come in who have normal T levels but are highly symptomatic? We do use surrogate markers in those patients, such as the presence of anemia, bone mineral density loss, or elevated hemoglobin A1C. And ultimately, guidelines are not a biblical dictum, and you're supposed to use your clinical judgment. These are the AUA guidelines suggesting improvements, and you can see nowhere on here do we talk about improvement in fertility. Yes, there are fertility-preserving testosterone therapies, such as selective estrogen receptor modulators, human chorionic gonadotropin, and aromatase inhibitors, especially in men with elevated estradiol levels or abnormal TE ratios. Wouldn't it be nice to know what the normal T levels are? This is an NHANES study, 1,500 healthy men, 20 to 44 years of age, published very recently, showing you that normal T levels, even in young men, are not particularly high. So let us avoid topping them up to supraphysiologic levels. What is a supraphysiologic level? If you look at these data from men 40 to 85 years of age, you'll see that we could accept that if your T level is above 1,200 nanograms per deciliter, we should consider that supraphysiologic. And it is routine in my practice in Manhattan, in New York, that I see men coming to me from low T treatment centers who have peak T levels in excess of 2,000. Why do we care? This is courtesy of Toby Kohler, the president of the Sexual Medicine Society of North America. What does supraphysiologic testosterone do? If we are just going to top up people, you put them at significant risk. And without going through all of these one by one, you can see that supraphysiologic T levels are associated with significant potential for major medical problems in our patients. So a rational approach to this patient would be to use good medical, scientific judgment to define fertility and sexual function goals and understand and communicate that just because somebody has low T, that testosterone level is not necessarily the cause of their sexual dysfunction or their fertility problems. Do not feel pressured by the patient to increase testosterone levels. Give patients realistic expectations, particularly with regard to spermatogenesis effects of exogenous T. Monitor post-treatment laboratory values. Assessment of symptomatology at 3 to 6 months. So we would be checking a semen analysis 3 to 6 months later. And our surrogate marker of intratesticular testosterone is 17-hydroxyprogesterone levels. And that's the driving force to when we get a semen analysis. And consider T therapy cessation if there's no response to T therapy. Finally, I'm going to leave you with this testosterone therapy checklist, which I think is very advantageous for your practice. There are 2 places you get into trouble as a practicing clinician giving patients exogenous testosterone. With transdermal testosterone, the risk of transference and the risk of fertility suppression. With that, thank you very much.